I'll shift it a little bit to move away from lipids into antiplatelet therapy, but I'll start with an adherence story. We recently did a trial looking at adherence to antiplatelet therapy in a post-MI population. And it was very interesting because I think in the US, like many parts of the world, cost of medication is so important. And so one of the key endpoints for us was, in fact, adherence to medications. And we could study medications several ways. One way is simply asking the patient, are you taking your medications? Have you gone several days without taking? Have you ever forgotten to take your medicines? How often do you forget to take your medicines? And we can quantify that. A second way is you could say, well, let me just call up the patient's pharmacy and see how many times they filled the medication and if there are any gaps in the fill. Because if the patient didn't buy the medicine, then they can't take the medicine. And then the third way is a very cynical way, is even if a patient buys their medicine and they go home, how do you know that the patient took that pill and put it in their mouth and actually took that medicine? So in this trial, we measured adherence all three ways. When you ask the patient, 85% of the patient says, I'm adherent to medications. I take my medicines without a gap more than, and we used a very liberal definition. We use 30 days. So 85% say I can go and not miss medications for more than 30 days. However, if you look at the pharmacy results, it's 55%. It drops by 30%. Even though the patient's telling you that they're taking their medications, 55% are actually shown to go and fill their prescription. So that's really, really important here. This is not related to my slides. I just wanted to give you that little story. So sometimes, what the patient tells you may not necessarily be true either. And in our current era where we're using things like electronic health records, so maybe we can look at fills, I think there could be some really great ways we can study and help our patients become more adherent to therapies. But I'm going to start with a case, and this is Peter. So Peter is a 68-year-old gentleman. He is from Nashville, Tennessee, and he came into the hospital with a non-ST elevation MI. This is not new for him. He had a coronary artery bypass surgery about 3 years ago. He's diabetic. His ejection fraction is 45% from his previous CABG. Hypertension, hyperlipidemia. And recently he's been doing relatively well. He's not had any major bleeding problems, no stroke. And because he came in with chest pain, he was given heparin and nitroglycerin, and he feels better. And so you plan the next day to take him to the cath lab and take a look at his coronary arteries. So I don't have fancy movies like Dr. Barnes does, so I'm just going to show you a still picture here. But as you can see, this is a vein graft that was from his previous coronary bypass surgery. This is a vein graft going to the OM territory, obtuse marginal territory. And this is a lesion that was noted in that area. His other graft, the lima to the LAD, was patent, and his native disease was pretty bad, which is why they needed to do the CABG several years ago. And his EF is unchanged. He's 45%. So at this point, we put a stent into this vein graft to the OM, and he feels better. But, and that's the picture of what happens afterwards. But here's the question for you. You are seeing Peter tonight. You have not yet cathed him. You know you're going to cath him tomorrow. What do you plan to do with his antiplatelet therapy tonight? And what do you plan to do with his antiplatelet therapy at the end of his hospitalization when he's ready to go home? And so here are some options, and I want you to think about them, and then I'll go through some data, and then we can come back and answer these questions at the end here. So your first option, and so there are two columns. The column on the left is what you do tonight as you're seeing Peter before you take him to the lab tomorrow. And then this right-hand column is what you're going to do at discharge when Peter's ready to go home. So your first option is to use aspirin, full dose, 325 milligrams, and then use clopidogrel, not quite a loading dose, 150 milligrams only. Remember, a loading dose is 300 or higher. And then at discharge, you could give him a low-dose aspirin, 81 milligrams, plus a maintenance dose of clopidogrel, 75. So that's option 1. Option 2, you give him a full dose of aspirin, 325. You give him a loading dose of ticagrelor, 180. And when the Peter is ready to go home, you give him an 81 milligram dose of aspirin and a maintenance 90 milligram dose of ticagrelor. Option C, we'll use 325 of aspirin again and a loading dose of prasugrel, 60 milligrams. And when Peter goes home, we'll keep him on 325 milligrams of aspirin and drop the prasugrel to 10 milligrams maintenance dose. And option 4, you do 325 milligrams of aspirin, but no P2Y12 inhibitor. And then at the end of the hospitalization, an 81 milligram dose of aspirin and 10 milligrams of prasugrel. So that's something for you to think about here. So we can spend all day long talking about antiplatelet and anticoagulants because it's a very robust pathway. There are lots of new therapies that are coming around. But today we're going to focus a little bit on the antiplatelets. So in particular, the P2Y12 inhibitors that really complement the aspirin here. So that's the key thing we're going to talk about here today. And our journey really started in the 1990s with a big trial called the CURE trial. Remember, at that time, we were treating patients with just aspirin. And so this was really the trial that started us thinking about drugs like clopidogrel. And when you compare clopidogrel to placebo, with everyone taking aspirin, we start seeing a very nice divergence in these curves early on and extending all the way to 12 months and even further, but an ultimate 20% lowering, 20% lowering in risk when we start using clopidogrel rather than a placebo. And this is particularly true for the patients who are treated with a percutaneous coronary intervention. Here we see a larger risk reduction of 31% here, is shown here. Now we know that if I took all of you in the audience and I fed you clopidogrel every day for a week, and then I took some blood from you and I tested it, about a third of you will be as if you've never taken the medication at all. So there are some patients who don't respond very, very well to clopidogrel because of the metabolism of the drug. So this is the reason why we started thinking about more potent antiplatelet agents like prasugrel and ticagrelor. The first trial for prasugrel was the Triton-TIMI-38 trial. Here, in this day and age when we were thinking about doing this trial, we can't not treat with clopidogrel because we already showed clopidogrel is good for you. So now our control arm is the clopidogrel arm, and then half of these patients were randomized to prasugrel. And very remarkably, you see these curves that are very similar to the CURE curves. They diverge very early, and they stay divergent all the way out to a year. And here we're seeing, again, an almost 20% risk reduction using this stronger antiplatelet agent. Now, it does come at some cost. If you use a stronger blood-thinning medicine, you expect more bleeding associated with that, and we see that as well here. Ticagrelor is very much like prasugrel, except it's a twice-daily medication, but it's also faster onset and stronger. And here we see the curves in the Plato trial in very much the same way, it diverges very early on, as you see here, and it stays divergent all the way out to 1 year. So compared with clopidogrel, patients treated with ticagrelor have a 14% lower risk of cardiovascular death, MI, or stroke. So as you think about the evolution of therapies for our MI patients, every step of the way we're improving patients by almost another 20% in terms of reducing their risk of cardiovascular adverse events. And because we are using stronger and stronger therapies, these columns here in the pink, this is bleeding risk. We do see a slight increase in that bleeding risk, but nowhere near the amount of benefit that we're seeing from a MACE, from a major adverse cardiovascular event standpoint. So while there is an increase down below going from here to here, really what we see here is a much more dramatic decrease in the events that we would really like to prevent here. And so what do guidelines tell us? Guidelines say it doesn't matter how you treat the MI patient. You could stent the patient, you could treat the patient with coronary artery bypass surgery, you could treat the patient with medical management alone. It doesn't matter. You should be thinking about using P2Y12 inhibitors for at least 12 months after the patient leaves the hospital after their acute MI. And so the guidelines really spell out that it doesn't matter what you do, 12 months should be what you do here. The guidelines also tell us, based on trials like Plato and Triton, that these newer drugs, the higher potency drugs, the ticagrelor and the prasugrel, patients treated with those do better over time. So it's reasonable for us to think about using this therapy in preference to clopidogrel, as long as the patient's not at higher risk of bleeding. The only patients we shouldn't be using prasugrel are the patients who've had a prior stroke or a TIA. Because in these patients, the risk of bleeding with the therapy far, far outweighs any potential benefit you can see from these therapies. So let's go back to the question that I asked at the very beginning here. Which therapy or combination of therapies would you think about for Peter? And as a reminder, Peter is someone who came in with a non-ST elevation MI, who you're planning to take to the cath lab tomorrow morning. And then hopefully he does well and you're hoping to send him home a few days later. So go ahead and vote and tell me which option you think about doing. I see a strong leaning towards option B, which I think is probably the right answer, but I'll talk a little bit more about that. So option A, clopidogrel, we like clopidogrel. It's an effective medication. More importantly, the patients can afford to take it. In the US, clopidogrel is somewhere along the lines of $10 a month, whereas and that's with insurance or without insurance. But for higher potency drugs like ticagrelor or prasugrel, those are usually a little bit more expensive. With insurance, they could be on average about $30 a month. So I think someone told me it was 1,500 pesos per month in the US. And then without insurance, it could be somewhere like $300 a month. It's quite a costly medication. The reason why A is perhaps not the right answer is because the loading dose is incorrect. If we're trying to get the best benefit from the drug, then we should load the patient properly. And so 300 milligrams is the correct loading dose, or I should say at least 300 milligram is the correct loading dose. If you think the patient's going to go to the cath lab very, very quickly, you might consider a 600 milligram loading dose. We in the past have also used 900, but often that just makes the patient vomit, so we try not to do that anymore. Option B is, I think, the dosing combination that has the most sense and is correct. You use a higher dose of both aspirin and ticagrelor early on, and then at discharge you convert to a lower maintenance dose for these patients. The reason option C is incorrect is we have already a randomized clinical trial called the ACOST trial that showed that pre-treatment, meaning treating with prasugrel before you cath the patient, doesn't give you any benefit whatsoever. In fact, all it does is increase bleeding risk. So for therapies like prasugrel, we often wait until after we do the cath before we decide that that's something we'd like to use for the patient. So that's why option C is incorrect. Option D, well, guidelines do tell us that we should try to use the P2Y12 inhibitor as soon as possible. So I think it may be a little challenging for us to think about not using something like clopidogrel or ticagrelor before cath. Now, some might say, well, what if you see surgical disease and you know you're going to cath the patient really early? Well, Peter's already had his cabbage, so it's unlikely that Peter's going to need another cabbage. So I think that's why for Peter, option D isn't really the right answer here. So very nice job here. So having said this, I would say in the US, clopidogrel also remains the most commonly used P2Y12 for cost reasons. I think more than half of our patients are treated with clopidogrel. But ticagrelor and prasugrel are probably used in about 40% or 45% of patients. It's a little different from Europe. Europe tends to use these higher potencies. They have a much stronger recommendation for the higher potency. It's class 1 for them. For us in the US, it's class 2A recommendation. So in Europe, it's more like 60% of the higher potencies and 40% of the clopidogrel. And I understand in Argentina, I think the clopidogrel is the treatment we most commonly use here. And that may also be because of cost reasons. So let's go back to Peter. So it's now 1 year later, after he's had his MI, and that he was treated with that drug-eluting stent to that obtuse marginal graft. He's done very, very well. He's been taking the medication we prescribed him for the last year. He has been adherent to the medication. He bruises easily, but no major bleeding. And he now comes to see you in the clinic. And remember, it's 1 year later. And so I want you to think about this question. 1 year later, he's doing fine. What do you want to do with his dual antiplatelet therapy at this point? Do you want to stop both of them? That's option A. Do you want to just stop the aspirin and continue the ticagrelor? That's option B. Do you want to stop the ticagrelor and just continue the aspirin? That's option C. Do you want to continue both of them as they currently are dosed? That's option D. Or for option E, you can continue the aspirin, but drop the ticagrelor dose just a little bit. And option F, oh, I guess there's some gesticulation. There's no Spanish version here? Okay. Or option F, you continue the aspirin, but you switch that ticagrelor to clopidogrel. So think about that a little bit, and I'm going to show you some data here. So there's been a lot of questions about who should get longer durations of dual antiplatelet therapy. And by longer, I mean more than 1 year in a post-MI patient. And so I think there are a number of ways you can think about it. First, of course, you talk to the patient, you examine the patient, and you base that on clinical judgment. The second is you could think about using validated risk scores, and I like that, especially if there's not a clear answer, and I'll go into that in a little bit. But a third thing you have to think about is what kind of patient preferences. So if the patient says, hey, doctor, you're making me poor because I keep spending money on medications and I need to spend money on something else, that might be something to think about. Or if the patient says, I need surgery, but my surgeon won't touch me while I'm on this therapy. So that's something else to think about as well. So all of these factor into this very individualized decision for your patient. Now, for someone who's had a stent, there are a number of clinical as well as angiographic features that predict the risk of stent thrombosis, which is something we all would like to avoid seeing. And so for patients, for example, who have diabetes or renal disease or multivessel disease or LV dysfunction, these are factors that predispose to stent thrombosis. And so we might use those factors to say this is a patient who can stay on therapy for a little bit longer. There are also angiographic characteristics. So for example, if you put in lots and lots and lots of stents, or the stent was in a position where you're not quite sure that stent is sticking to the wall very nicely, or the stent's in a very critical position that if a thrombose, like the left main or the prox LAD, where you know a stent thrombosis would be very dangerous, that would be another reason to try to keep patients on treatment longer. And so these are the factors that go into my clinical evaluation when I'm deciding what to do 1 year later. From a trial standpoint, I think one of the most interesting trials here is the Pegasus trial. Now, this was a trial who took patients who are 1 to 3 years out from their MI. And at this point, they randomized the patients into one of 3 groups. The first group is placebo. So that means if they were still on something at the time of the trial initiation, they would come off of it, okay? And they would just stay on aspirin, 81 milligrams once a day. The second group was treated with ticagrelor, 90 milligrams twice a day. And that, remember, is the ACS dose, okay? So they would stick with that. And then the third group is still staying on ticagrelor, but at a much lower dose, 60 milligrams twice a day. And this is a brand new dose that was studied in this trial. And the thought is, you're now 1 to 3 years out from the MI. You might benefit from it, but maybe you don't need as high of a dose. And the main primary outcome here was the same one, CV death, MI, and stroke. And again, what we see here is that the patients who are treated with ticagrelor this far out from their MI event, 1 to 3 years out, they still benefit from the ticagrelor. These patients still do better over time. And interestingly, the patients who got the 60 milligram dose did as well as the patients who got the 90 milligram dose. Now let's look at bleeding, because there's no free lunch. If you treat with something, you should see a side effect from that medication, and we do. The patients who are treated with the ticagrelor, they are more likely to have bleeding, low risk, and fortunately not terrible bleeding, so not fatal bleeding, not intracranial hemorrhage, but still minor and major bleeding. And the 60 milligram dose, the one in red here, is a little bit less than the 90 milligram dose. So perhaps if you get the same benefit with the 60 milligram and much less side effect in terms of avoidance of bleeding, then perhaps 60 milligrams would be the dose you would think about using for these patients. And if you compare Pegasus with many of the other trials that are much smaller, this was a meta-analysis, what you see is that continuing treatment beyond 1 year in general is associated with about a 1% absolute risk reduction in CV death, MI, or stroke. So very effective here. It is associated with a hazard ratio of 1.73, so a 70% relative increase in the risk of bleeding, okay, which translates to about a 0.8% absolute increase. Okay, so keep in mind 1.1% decrease, 0.8% absolute increase in bleeding. So that's the trade-off that you need to think about. And now you have to individualize to that patient who's sitting in front of you. So this really just summarizes what I said. So one of the scores that I often use when I don't really have strong feelings either way is the DAPT score. And DAPT is only one of several scores. There's also the DAPT Precise score, and Roxana Moran has another score out there as well. But this is one for me that's very easy to use because it takes a number of clinical and some angiographic characteristics, and you add up the points. And if the points are greater than 2 or greater, then these are the patients who might benefit from longer treatment. So let's take Peter. Peter was 68 years old. 1 year later, he's 69 years old, so he's still within that range, so that's -1. Peter was, where's the second box? There you go. Peter's diabetic, so that's another +1. Peter had an MI at the time when his stent was put in, so that's another +1. And then Peter had a stent put into that saphenous vein graft. So if you sum all of that up, that's +3. That would suggest to me that Peter should benefit from longer-term antiplatelet therapy here. So I think I've kind of given you the answer, but why don't you go ahead and vote here for what you would like to do with Peter. I think many of you are thinking about Peter's wallet more. So many of you are picking option C, but the columns are changing. We'll give it a little bit more time. Got 41 votes so far. We can keep going. So the most popular answer is option C, which is continue the aspirin but stop the ticagrelor. And I would say in the US, many people would do the same thing. As I mentioned, ticagrelor is $30 a month, and it's hard for patients sometimes to bear that financial burden. The second most common answer is option E. And I think that would also, from a clinical standpoint, if cost wasn't an issue, I would say that that is the correct answer, because we looked at his DAPT score and it was +3. So that suggests that the benefit of continuing treatment is far greater than the risk of continuing treatment. And if you were to compare the 90 milligram dose versus the 60 milligram dose, both seem to have the same efficacy, but the 60 milligram dose may be safer with less bleeding. And so that would probably be my choice, assuming that Peter can afford to continue to take that treatment here. So great. I think that's the end of my slides. More answers are changing. Maybe E will now win.
Maybe you just, it just did. You need to just stand there, Tracy.
Oh, look, E won, yay!
You've had an effective education session.
Good.